Petrucka is a nurse researcher and an associate professor with the College of Nursing, University of Saskatchewan, Regina site. Her current research program focuses on the health of diverse and vulnerable populations. Through community-based participatory research and evaluation strategies, she has ongoing research partnerships in Saskatchewan, the Caribbean, Kenya, and Tanzania. Her current research areas include Aboriginal health policy, diversity and globalization in rural and remote women's health, rural and remote areas, women's health, and information and communication technology for development, ICT4D. Thank you, Dr. Petrucka, for being here with us. And I'm going to just publish the poll now, and then we will just move on quickly to your presentation. Okay, so there is the representation that most persons have considered all those areas in their field.
Good morning. I'm hoping you can hear me, and if you can't, I'll check in the chat area. Thank you for this unique opportunity to talk about a project that has actually completed and has begun a new phase, and I'm hoping you'll be able to see how we've connected what we were fortunate enough to have nearly 5 years of working on the ground through the Caribbean, through 5 countries in the Caribbean. The project that we have, and you'll see that my co-presenter, Dr. Sandra Bazandowski, who's actually en route to Kuala Lumpur to present for us, was entitled Enhancing Nursing Care and Quality Through Technology and Beyond. So I'm hoping to present to you a bit about the lessons that were learned in our experience, as well as to take you through the pathway that we followed. And I'm just hoping that I can get this slide to work, so bear with me for half a second. There we go. So the ENACT project, as it fondly became known to us, began in 2007, and for many of us, I'd like to just take you back a half thought process to where 2007 there was really a lack of access to many ICTs. In fact, when we were starting with our work in the Dominican Republic, we in fact didn't even have nursing colleagues who knew how to text message, or who had, many of them had never even been able to do any kind of texting or SMSing. So we were actually working at very, very basic levels in 2007 with some of our participants. Through the project, we were, which was funded through IDRC, we were very privileged to be able to work consistently in 4 countries. And our intention at the beginning, our initial emphasis, was to introduce nurses, to give them a working knowledge of ICTs and basic applications of handheld devices. So we started with PDAs, we morphed into smartphones as they became more available, and by the end of the project we'd actually moved into simulation devices. So the project kind of gained momentum as we went along, and it morphed as the technologies improved, which was a really important learning, and is one that is important as you look at your initiatives, that as the technologies change, we need to be responsive, not necessarily by buying into the newest thing, and our present research is really looking more at disruptive technologies and what those technologies are. So this experience in the Caribbean was really important for us to get an understanding of the difference between accessible technologies and those ones that are disruptive and can actually make a difference. And so I'm hoping as I speak that will come through. So the ENACT project at its inception was extremely committed to improving or increasing utilization by nurses of ICTs in an effort to help them to improve their point of care access to information. So information literally in the palm of their hands. And that was really the drive. And if you can see the picture on the slide, these were our colleagues in the Dominican Republic, and the smiles were genuine because for many of them, this was so new. The gentleman that's there actually, just as a point of reference, has gone on to study ICTs because he became very interested in and engaged in the process. So these to me were important ways to move forward that agenda within healthcare. The reason for nurses, I must say, wasn't because I'm a nurse. In fact, it wasn't our initial target group, but in working with our funder, IDRC, the feeling was that nurses were the ones that were the most ubiquitous within the health system. They were out there, and so they were a great target for us. The second thing that we really aimed at was evidence-based care and decision-making, and that was a novel concept in 2007 for many of these people, and it remains so, I would think, for many of us. It's still one of those nebulous areas, and it was one that we felt that giving the technology gave the knowledge opportunities and learning. And that materialized or operationalized rather in a unique partnership with Nurse One, which is the Canadian Nurses Association, who provided access for the Caribbean nurses to their large database, all of their libraries, and a number of other sources, which was unique at that time given that we didn't have Hanari and a number of the open source publications. So for many of the nurses, just being able to look up something, I have a great story in St. Lucia where the nurse manager that I was working with stayed up all night, and she was very thrilled, and I asked her why she stayed up looking on something all night, and she said she had been trying to find a reference or a resource book that they were looking at some quality management work, and she thought that this was a one-time access, and so she felt she had to collect every piece of information she could. So evidence-based and decision-making was an important component. Also, basic data collection and analysis, and that included remote monitoring. In our scenario, we originally were hospital-based only, but especially in St. Lucia and St. Kitts and Nevis, we were pushed on the margins by the nurses. As we worked with them, they were the ones who called us to action to move beyond the borders of the hospitals and go to a hospital without walls concept. So our focus in working with the nurses was around diabetes monitoring in the hospital and in hypertension, like blood pressure monitoring. And in the end, we ended up doing those on the streets in Dominica, in the barber shops in St. Lucia, at a public fair in St. Kitts. So we constantly moved around based on where the nurses felt that they could get access, collected data, put it through their handheld devices, were able to capture the data in real or near real time, as well as providing information and care to the clients. Additionally, the nurses made use of those devices to talk to a patient about a particular health concern or look up something on that particular condition or case that individual was experiencing. So it became very interesting. Early on, patients were quite uncomfortable, and at one point nurses were told, well, do not know anything, that you have to look it up. They were overusing the devices at times they felt so empowered. And so we learned very quickly that it was a balance. And then information sharing was that latter component. So not only did the information sharing, which originally the information sharing intent of our project had been nurse to nurse, nurse to physician, nurse to other colleagues, risk techs, whatever. And in the end, it was really information sharing mostly between the nurse and the client groups, which was really an interesting evolution for us. This diagram is a little busy, but I thought it would interest people in terms of that we realized that there was a human capacity, much like our previous speakers spoke to, the need for capacity building was important. Much like our previous speakers spoke about the need for those technologies to be present and available. And then what we found was when you put those combinations together, an empowered and capable grouping of people along with the necessary tools, you suddenly are able to look at quality, professional development and continuous learning models for those people, as well as challenging the decision makers and challenging the policy forum. And that became very embedded by the nurses themselves going forward and speaking to the policymakers and talking about the need for us to have, in one country, the motto that came out of one of the policymakers was, we really need one device per nurse or per professional. And it was interesting to see how they were understanding that those devices weren't just about connection and linkage, but they were about knowledge and evidence. So that was a huge switch for us. So we really strove to address local priorities. When we started the project, we asked what their priorities were, and interestingly enough, reflects quite closely with our previous speaker around the non-communicable chronic type of diseases. They didn't ask for information on operating room techniques or those types of things. They really went to needing current information for practitioners, patients, and the public in order to alleviate or to address those particular ones. And the three that we ended up focusing on were diabetes, hypertension, HIV/AIDS, and in the end, the HIV/AIDS was mostly information sharing, currency of data, currency of practices, whereas the other two were really about data capture, getting out, and outreach. So that's where your public health emerged again, was in those types of areas. Addressing local priorities also took us down the road of capacity building, which I've already alluded to. In this case, we found that there was basic need for informatics skills, which has morphed considerably in the 5 or 6 years as our project emerged and evolved. What we did find, though, we were able to, thanks to the funding, do some really innovative things on podcasting. And podcasting became a very easy way for us to share knowledge across islands, to share cases. People would capture a particular case that was interesting or a particular idea. So, for example, the barbershop idea was wonderful. This was from one of our colleagues who said, it was the 13th of February, the day before Valentine's Day, and she said, today's a good day to go get all those men. And I'm like, what do you mean? And she said, they're all going to be hanging at the barbershops because they want to look good for their women. And so we ended up going to the barbershops, and we went from barbershop to barbershop, and we must have done between 50 and 60 per barbershop, individuals, blood pressure and blood sugar monitoring, gave them some information, talked about choices, healthier choices, talked about the connection of smoking, so we were able to do very innovative. And for me, as I'm a Canadian, uncomfortable. I wouldn't be that comfortable going to a barbershop and doing it, but there it became very much the place where the men met, they shared an idea, they talked openly, and it was a very facilitative environment, and the devices facilitated it. They also became a bit of the talk. The men were interested in this and were interested in how that information would be shared. So it was part of the process. So the podcasting worked. The remote monitoring was the tie-in of capturing the data real time and sharing it so we could sort of project what were the trends and some epidemiological capture, and then the nurse one, which was the actual data. The patient satisfaction I've touched on, where people were really responsive and interested in what we were doing, how it would help them. They were curious why it wasn't available to their children, why we weren't in the schools, which was a big insight for us as well. So our highlights, we saw a significant increase in interprofessional practices. We saw great use of evidence happening because we were able to share across very quickly and in a very novel way. People were interested in looking at that screen and talking about, well, what was being said, or where did you find that information? Additionally, there was a sense of support amongst the nurses, that they felt supported and they felt empowered. Additionally, we found that there was an increase in use of technology that became concomitant with the opportunity. So it wasn't necessarily that the technology drove the increase, it was because as they saw that the use and the utility, the growth was there and it was spontaneous. They looked for learning opportunities, they looked for ways to take us beyond our original plan, which was amazing. And then they created, there was a creation of a health information and knowledge exchange environment, which has resulted in an ongoing relationship where we do teaching, we have classes that we offer using technology, where we do pedagogy and teaching on research and teaching methods for their clinical education. And that's been just an ongoing support network. The lowlights, we had minimal impact on policy, which we really were hoping to do more of. May have been time limited, may have just been the environment was changing and the technologies were changing very quickly. There was institutional resistance to technologies at times. The interprofessional empowerment struggles continued, and not always a recognition by the institution why this was an important investment. Also, the complexities were were involved with the extension to the community. We didn't have the ins that we probably would have liked to have had, and that came after the fact. And the sustainability components had to have been built in better. We struggled with so what at the end, and where would this go? So I think we didn't succeed on all elements, and we would like to flag those for people considering future efforts. Presently, I've talked about the continuing education and that we're doing these research and evaluation capacity skills kind of sessions. But my more exciting is that we've had some promising practices that we've taken with us to other projects. Health Information for All has been a really big impetus in a project that we're doing in Tanzania, where we're building information kiosks using the same principles and the same technologies that we used in the Caribbean. And the interprofessional capacity building and communication strategies have also been a great learning. In fact, if you take time to read some of the articles that we've listed, you'll see that the south to north learning on this project was amazing. We actually replicated what we did in the Caribbean and brought it with us to Canada to some of our Aboriginal communities. And I'd invite you to take a look at what we've done in those. As I say, in Tanzania, we're doing the health information concept, but we're also using, right now, a concept on birth spacing that we will be using that will combine technology, SMS push messaging, similar to what our previous speakers spoke of, based in health protocol algorithmic medicine to underpin creation of a beaded birth calendar. And we're just working on the details, so we would actually, in our prenatal, postnatal classes, teach the women, do beading or reading, depending on the culture, based on a color scheme. And in each of those beaded sections, and this is really quick, would teach them about what are their risks, what are the key steps that they should undertake to be healthy during that period. So don't get pregnant while you're breastfeeding, and these are the steps that you would need, 6 months prior. You should be taking folic acid before you consider the next baby. And so it would be color-coded birth calendars, but it would be underpinned with SMS text messaging, focusing on a first 1,000 days approach. So it's a little bit complicated. It's emerging, and I'd encourage you to watch to see where we're at with that. That is what I'd like to present. There is some of our select publications that I would hope would inform you and lead you through some of our learnings. And I'll look forward to the discussion from here forward.
Thank you so much, Dr. Petrucka. I think that was a really excellent presentation, another excellent presentation. I mean, it was very entertaining as well, especially from my point of view as a Caribbean person, listening to the stories about the barbershop and those kinds of interventions that are really unique to the culture of the Caribbean but work for us. I just really enjoyed that presentation, and thank you for taking the time to be with us this morning to share your work in this area. At this time, I'd like to open up the floor for the question and answer part of the session. Persons can ask questions by either raising their hand, which is just below the participants. The word participants, there is a button with a little tiny hand. If you click it, you can raise your hand. Alternatively, you can write a question in the chat section of the Blackboard. Okay, I'd like to go ahead and let Nassim ask his question, followed by Kisoon and then Andrea. Thank you.
Thank you to both presenters. Both presentations were very, very interesting. I have a question for Professor Hassell. I would like to ask him what, in his opinion, were the greatest challenges that Healthy Caribbean Coalition faced when trying to implement their web-based strategies, such as Get the Message campaign.
Yeah, well, thanks very much for that question. Yeah, there were many challenges. First of all, one of the challenges is that this was a new experience. This was an entirely new experience. That's the first thing. The other aspect, one of the other challenges resided around the use of the mobile phones, because there was a need to convince the mobile phone service providers that this was if you will, a good, they were being good corporate citizens by making both the text blasts or the text messages free of cost, as well as the response from those who wanted to respond yes. I mentioned also that the cost, the cost was not prohibitive, but there was nevertheless the cost, and this was this was a challenge, trying to find funding. We were fortunate in that the funding, such as it was provided by the regional insurance company that was one of the partners. So the other aspect that I think it's important to mention is that that when we engage in web-based initiatives, we often are of the view, certainly in the Caribbean, is that they can be successful in their own right, so to speak. But one of the things we learned was that it was necessary to also engage the traditional media, so print and radio, to use the traditional media to direct persons to the web-based aspect of the campaign. So those were some of the issues. One of the very positive things about the Caribbean is that there's a very high penetration of mobile phones, and so that was not an issue, because one could argue at one point that there's not a significant distribution of mobile phones, and so therefore that's not an appropriate method of communicating. But that's not true in the Caribbean, where there's truly a significant penetration. I hope that's sort of begun to answer your questions. And let me say that I'll be available to answer and follow up on any issues after this has been completed.
Thank you, Professor Hassell. Kisoon and then Andrea. Kisoon, would you like to use the talk button to answer?
Oh, hello, good morning. Thank you very much for their wonderful presentations. I might have missed this start. This is a question to Professor Hassell. I just wondered if you have any disaggregation by territory, if the project had.
I'm sorry, Kisoon, your audio is a bit blurred, so I'm going to ask if you can just type your question in the chat in the meantime. I'm going to just let Andrea Cortino ask his question so that you have some time to type. Thank you.
Thank you, Soraya. And I wanted to thank both presenters for these really interesting contributions. And I love the opportunity, because I think that this is the very heart of the ESAC project, an opportunity to share stories, experiences, questions, and open a dialogue on the opportunities created by technologies beyond clinical care. So thank you very much to both of you, and Pammla, it's a pleasure to meet you again here. I have a question about a point that Pammla expressed very explicitly in her presentation, but that I'm sure it's also part of Sir Hassell's experience, which is about the problem with the institutional resistance to the introduction of technology and the impact that such a resistance could have directly and indirectly on long-term sustainability. And I would love to ask both of you, if you like, to perhaps expand a little bit on these issues particularly. Thank you.
Dr. Petrucka, would you like to go first, and then Sir Hassell?
Sure. Can you hear me? Yes, I can. I see it moving now. Yeah, thank you. And Andres, thanks. It's nice to hear your voice. I think the reason we found the resistance, I guess the issue for us was basically that the resistance was sometimes based on false understanding or misunderstanding or an immaturity of understanding of what ICT's potentials were. And we felt that oftentimes we ourselves were probably not as good messengers as we needed to be. And as we're moving, I believe, in this world to much more of a ubiquitous health approach using ICTs, I think that we didn't have the tools, and we as practitioners didn't have the insights or the abilities to convey that in a way that I don't believe we had to sell the message, and we didn't have to be mercenary about it, but we needed to be better ambassadors as to what ICT's potentials were, and realistically, like there are drawbacks and there are risks. I also think that there's a fallacy around the cost, and cost has come up a couple times with my colleague speaker, and I found that the cost is really not as dramatic as is often put into the fold. And yes, there is a cost, and that's real, but there's also a cost to doing business, and there's an opportunity cost if we don't do this business. And so we were trying in our formative time to try to impress on and with organizations that ability to use this technology actually has that long-term upstream benefit. And if we could get them to start thinking in those upstream terms, institutions tend to be very downstream, very here and now. And so that was the component that we felt we didn't achieve. And so the sustainability for us really would have lied in some type of a upstream thinking process if we could have planted that seed. I don't believe we were successful, but I do believe we opened the door to the dialogue, and people like, Sir Hassell and others who are doing it on a constant basis in these very innovative ways with the civil society, I believe they have that opportunity to continue to make that mark. I hope that answered it somewhat, and I'll turn it back to my colleague speaker.
Yeah, so I suppose from my perspective, or our perspective, as it relates to resistance to ICT, yes, I've got to put cost at the top of the list. First of all, given the nature of the projects that we have used the ICT for, I think validity is another issue. I think. I wouldn't wish to, I'm not sure this comes in the category of resistance, but certainly it's been a challenge to engage the mobile phone service providers to the extent that certainly we in the Healthy Caribbean Coalition would wish to have engaged them. And so I think going forward, if we are to really get to use ICT in a meaningful way, that we've got to engage the policymakers, the governments of the day, so that if we can find a way of getting the governments to come on board with respect to the use of ICT as a tool for the response to NCDs, then I think much of the quote-unquote resistance is likely then to be overcome. I don't know if that answers your question. I'm prepared to further if necessary.
Thank you, Dr. Petrucka and Sir Hassell. I want to ask the question on behalf of Kisoon in the chat. He asks Professor Hassell, is there any information related to the project's implementation in Guyana in terms of responses, etc.?
Yes, well, so we shared with you 4 of our projects. The Get the Message campaign, that's concluded, and certainly we had responses from Guyana, and I can easily give you the specific number of responses we received from Guyana, because we have that data as to which countries we secured the responses from. That's with respect to the Get the Message campaign. With respect to the cervical cancer campaign, which is ongoing, our main contact in Guyana is Fiona Legal of the Cancer Institute of Guyana, and she is involved in several aspects of that project. But as far as the electronic petition component of the cervical cancer program is concerned, all one needs to do, irrespective of the country one is living in, is to just simply go online and Google End Cervical Cancer Now, and sign the petition and promote the petition throughout the country among your friends, among your colleagues. So I am here now extending an invitation to my colleague in Guyana to feel free to promote the electronic petition, because clearly the more successful that is, in other words, the larger number of persons signing the petition, the more likely it is that we will get a positive response to our call to action to the heads of government of CARICOM, because ultimately we will be presenting the results of the electronic petition to the heads of government of CARICOM. But by way of a side note, although I speak to the electronic petition mostly in terms of advocacy, it is important to appreciate that it also is about education, because there's a lot of information that is provided as part of the electronic petition. Again, let me say that we are looking to scale up some of our programs, and certainly we would be keen to have an advocate and a supporter in Guyana who has an interest in ICT and who might want to lead on 1 or 2 of our upcoming projects. So perhaps focus on the future projects aspect of the presentation, and perhaps we can exchange emails, to see how you might contribute.
Okay, thank you, Sir Hassell. Kisoon, I hope that answers your question. Great. You will have noticed in the chat section that I posted a place where after this session we can continue the dialogue about this. I have another question for both presenters, however. How do you think we can encourage projects of this nature? I know Dr. Petrucka alluded to the fact that sometimes these projects they're more isolated in nature, and they don't necessarily have an impact on policy as much as we would like. What do you think some of the steps are that we could take to have that impact in policy and ensure that there are more projects like these throughout the Caribbean?
As I said, on this end, both I am here as well as the manager of the Healthy Caribbean Coalition. I'm going to let her respond to that because I think she has some very definite views with which I concur entirely. But I think she may wish to express them herself.
Hi there, everyone. This is Maisha. I think in response to your question, Soraya, there are two areas. One is to demonstrate to the populace, to individuals out there, that this is a useful tool that can indeed benefit them. So going back to our petition, one of the major things we're working on right now as we go through the petition process is speaking with PAHO and CARICOM about mechanisms for recognizing e-advocacy so that there is actually something institutionalized so that people know when they sign a petition of this sort, it actually is going to achieve some sort of change or will move towards change and along a continuum of sorts. So that's one thing. If people know that their efforts, whether it's signing a petition online or texting in support of something or supporting an program will actually lead to change, I think they're more inclined to do it. And secondly is funding in this area. That's been a challenge for us as well. So, eHealth programs are generally underfunded compared to other types of programs because it's such a new and niche area. So we need to start getting funding agencies and donor agencies interested in this new area so they can start funding these programs.
I concur. I might add a couple things. One would be that I believe that there's an imperative for embeddedness, that this has to be embedded in training of professionals, in the dockets that we take forward, the briefing notes that we bring. It has to be embedded in all of our documentations as we're fostering and advocating for public health generally and public e-health specifically. So I think that message and those strategies have to be made explicit, what we've often done implicitly and sort of off the edge of our desk. And the second element that I might add is that we need to find champions and identify and work with those champions more successfully. I must say that in one of our situations, one of the islands we worked on, St. Kitts, it's no mystery. The Prime Minister actually came and spent the day with us and went through the training with our nurses and participated really fully and was really very engaged. And I think you need somebody like that to become very involved. And he actually assigned us somebody in their health department to work with, and then assigned us somebody in the education unit to work with. And so we had momentum build through that champion. And so I think that would be another really key strategy that people need to identify who are the people who have that understanding and have the capacity to help us move that agenda. And I think the encouraging part is it is happening. Despite or in spite of the policy, people are taking it on. The civil society effort that you've just spoken of in the other presentation is very it's very heartwarming to me and very positive. I know the nurses that we worked with have taken it forward and were very strong. Nurses actually went out and bought their own devices at a time when technology was expensive. There is that desire to move it forward, and I think it only needs you're at a tipping point, and I think this is the type of forum that you can use it through, and I'm very pleased to have had this opportunity. So thank you, and I hope that assisted in answering some of that question.
Thank you, Dr. Petrucka, and thank you, Sir Hassell. I think those were really excellent answers that we will be sure to make a note of for the ESAC project and sharing with everyone that wasn't here. I just want to say thank you again to all of the presenters. Is there anywhere that we can get a summary of Dr. Petrucka's project, Sir Hassell asked in the chat? Perhaps you could answer that in the chat, Dr. Petrucka? Okay, great. Yes, so I would like to thank Dr. Petrucka and Sir Hassell for really excellent presentations this morning, the second in the three-part series. We will be recording, or we have recorded the session, and we will be sharing the session. We are aware that, if you came in late, maybe it was daylight saving time that was the issue that just changed on Sunday. So we are aware that persons are not on the appropriate time as yet, but we will be sharing this on our YouTube page. I've also posted the link in the chat of the forum, which continues after this session, where further questions can be asked. And as soon as we have the video from this session, we will be sharing it on the ESAC YouTube site. So thank you again, presenters. Thank you, PAHO and University of Toronto and the IDRC for your support. And I would just like to say see you next week for the March 18, the final in the series, Public eHealth, How to, Policy and Implementation. We have 3 great speakers next week, so I hope to see you all again at the same time, 10 a.m. Washington, D.C. time, here in the ESAC virtual meeting room. Thank you all and have a wonderful day.